In this video, we'll discuss about tips for facial nerve identification during parotidectomy. Parotidectomy is the treatment option for parotid gland tumors. It could be the superficial or total or radical parotidectomy based on the nature and extent of the tumor. Right? So, the main concern when you are doing parotidectomy is to preserve and identify the facial nerve to avoid injury to the facial nerve. So, basically there are two methods for identification of the facial nerve during parotidectomy. The first one is called as retrograde approach and second one is called as anterograde approach. First we will discuss anterograde approach because this is the conventional approach and most commonly used. Right? So, in this approach, there are almost 6 landmarks based on which you should identify the facial nerve trunk. You know that facial nerve exits the skull through stylomastoid foramen. Right? After it exits and before it enters the parotid gland. That means from the stylomastoid foramen to the until it enters the parotid gland. That is called as main trunk. So in anterograde approach, we will first identify the main trunk of the facial nerve. Then we will trace to the peripheral branches. Right? Whereas in case of retrograde approach, first we will identify some peripheral branches and we follow that branches to the main trunk. Right? That is the main difference. Okay? So in anterograde approach, this is most commonly used one and the most important landmark is the tragal pointer. That is cartilaginous external auditory meatus pointer. In this diagram you can see here, the external auditory meatus is formed by both bone and cartilage. Right? So this is the tympanic membrane and this will be your middle ear. And this is the external auditory meatus. This is external pinna and this is the bony part and this blue colored one is nothing but the cartilaginous part of the external auditory meatus. So, in cartilaginous point, this cartilage produces a pointer, that is this one, right? This is the cartilaginous external auditory meatus point. So facial nerve, the direction of this point shows the direction of facial nerve, right? So facial nerve lies 1 to 1.5 centimeter deep and anterior-inferior to this tragal pointer, right? So in this diagram you can see here. In this diagram, this is the bony external auditory meatus, this black colored one, and this blue colored one is nothing but the cartilaginous external auditory meatus, and this is the mastoid process, and this will be your mandibular fossa, and this is the zygomatic arch, and this green colored one is nothing but the parotid gland. This is the orientation, right? So this is the tragal pointer. This point, this blue colored point is nothing but the tragal pointer. To this tragal pointer, facial nerve lies 1 to 1.5 centimeter deep and anterior inferior to that point. Right? So that is the main important landmark used for the identification of the facial nerve main trunk. And second landmark is tympanomastoid suture. That is the suture between the tympanic bone and mastoid process. Right? To this suture, facial nerve lies 6 to 8 mm distal to the end point of the suture. You can see here. This is nothing but this is the mastoid process and this is the bony external auditory meatus. So this is nothing but your tympanomastoid suture. And third landmark is posterior belly of digastric. Right? So you know both posterior belly of digastric and sternocleidomastoid muscles attaches on the mastoid process. So you have to retract the sternocleidomastoid. This is nothing but the sternocleidomastoid muscle and this is nothing but the posterior belly of digastric. So you have to retract the sternocleidomastoid muscle so that you can see the posterior belly of digastric muscle. To the medial point of insertion of posterior belly of digastric, there is the stylomastoid foramen, right? So this is nothing but the stylomastoid foramen, and from this foramen to the until it enters the parotid gland, this is called as main trunk. So first we'll identify main trunk. After that we'll trace out the peripheral branches in the anterograde approach, right? So this is third point. And fourth one is nothing but styloid process. Some advocates styloid process can be used, but some are against it because there are high chances of injury to the nerve if you follow the styloid process as a landmark. Because styloid process, to the styloid process, facial nerve runs superficially and obliquely crossing the styloid process. So in the process of identification of styloid process, there may be the chances of injury to the facial nerve. And fifth one is removal of mastoid tip, especially in the cases of fibrosis, that is for recurrent tumors. If you are doing parotidectomy for recurrent tumor, right, there is fibrosis due to the earlier surgery. In that case, there may be the difficulty to identify the main trunk. In this case, you can go for removal of the mastoid tip so that you can directly identify the stylomastoid foramen, right? After that, transfer process of the atlas. Atlas is nothing but the first cervical vertebrae. So if you follow transfer process of first cervical vertebrae, then you can identify the facial nerve, right? So this is about anterograde approach. In retrograde approach, the most commonly used landmark is nothing but buccal branch of identification. Buccal branch identification, right? So you know there are 5 peripheral branches for facial nerve, right? So within the parotid gland, the main trunk of the facial nerve is again divided into the zygomaticotemporal branch and buccocervical, or zygomaticofacial, or temporofacial, or buccofacial branches. That means it is divided into 2 main branches, right? From the zygomaticotemporal branch, again we will get, this is nothing but the temporal branch and this is nothing but zygomatic branch. From buccocervical branch, we will have the buccal branch and marginal mandibular, and this is the cervical, right? These are the 5 terminal branches. You can see like this, right? So we'll first, in a retrograde approach, first we have to identify the buccal branch, because buccal branch of the facial nerve runs alongside of the parotid duct, right? You know this green colored one is nothing but the parotid duct. This is the parotid duct. Alongside of this, there is the buccal branch. This is the buccal branch. Again, it is divided into upper buccal and lower buccal. Upper buccal is for upper lip, lower buccal is for lower lip. So if you identify the buccal branch, which can be easily identified by identifying the parotid duct. That means first you have to identify the parotid duct. After that you can identify easily buccal branch. Then you have to follow that branch to the main trunk. That is the most commonly used method. And second is by identifying a marginal mandibular branch, right? This branch can be easily identified by identifying retromandibular vein. You know that both retromandibular vein and marginal mandibular branch emerges from the parotid gland at the inferior border, right? This is the inferior border and this is the superior border, anterior border and posterior border of the parotid gland. This blue colored one is nothing but the retromandibular vein and this is nothing but the marginal mandibular branch. So you have to identify retromandibular, after that marginal mandibular, and you have to follow the marginal mandibular to the main trunk. In this way, you can identify the facial nerve. And one important thing is, facial nerve doesn't enter the substance of parotid gland. It always lies in between the superficial and deep lobe of the parotid gland. You can see here, this is nothing but the larger superficial lobe and this is the small deep lobe. These 2 lobes are interconnected by isthmus. So in between two lobes, there is the facial nerve. It doesn't enter the substance of parotid gland, so that you can easily demarcate the facial nerve and parotid gland substance. In some cases, that is when the infiltrating tumor is there or the tumor is very large, in those cases there may be the difficulty. But these are the two approaches used, right? Most commonly we will use this one. There are some instances when there is fibrosis due to the earlier surgery, or if there is large infiltrating tumor, or there is recurrent tumor, or small parotid tumor in tail region, right? That means in this region, if there is parotid tumor in the tail region, that is inferior end. So in these cases you will go for retrograde approach, right? Retrograde approach. But the disadvantage of this approach is that it is time consuming, right? This is the time consuming. This is most important practical tips, right? In mastoid process also, after identification of mastoid process, you have to place your index finger on the mastoid process and you have to bisect that index finger. That means if this is the mastoid process and I will place my index finger there and I have to bisect that index finger, that direction will direct to you to the facial nerve, right? This is also one most important thing. This is all about facial nerve identification during the parotidectomy. We'll discuss about parotidectomy in a separate video. If you like this video, hit the like button, share the video, subscribe the channel.